very fascinating case which has got a very much relevance in clinical practice, because generally what we say is that we often will talk about physiology and pathology, and often certain scenarios in pediatric endocrinology will be such which will be a marker of a serious disease which may often be missed with disastrous consequences. So we'll talk about a common presentation with an uncommon cause in which there were a lot of issues. It's part of our Grand On series which we do every month, and you all can have a look at our website learning.rosociety.in, which has got a lot of information about pediatric endocrinology. We've got various courses which are available, including a comprehensive fellowship and a diploma course. There are a lot of programs going on in terms of the journal clubs, in terms of the lecture series that we have, and the publications and mobile applications which are available. So today we're going to focus about a very interesting case of a delayed puberty, which really emphasizes how a common condition, a pediatric endocrine condition, can have huge implications in terms of the outcome.
Yes, sir. Good afternoon, everybody. So we recently had a 16-year-old girl in the office who had visited a pediatrician for complaints of delayed puberty. She also had all of mild to moderate executive worry, but she had no vomiting, no visual symptoms, and no incontinence. On examination, her age and height was appropriate for age. The SMR was B2B1. Initial workup.
So just hold on from there. So now, if you talk about a 16-year-old girl who has come to you with delayed puberty, what are the key 1, 2, 3 possibilities you will think? What is the most likely cause in this scenario?
Delayed puberty is rare in girls. In boys, it may be physiological, but delayed puberty is just rare in girls. So we will like to think of in lines of.
So, if you forget about this particular age or other demographics, if I just say, what about delayed puberty in girls? What are the various proportion of cases you will think of in terms of etiology? So how many cases you think? How percentage wise? So 35 to 40% will actually be CDGP. Then you will have a group like 20%, 30% will actually be something like Turner syndrome. So hypergonadotropic hypogonadism. Then 15-20% will be systemic illness, and 15% roughly will be hypergonadotropic hypogonadism. So still the leading cause will be CDGP. In boys, the chance will be double. So it will be like 60-70%. Now, what I'm trying to say is that what are the pointers? So when you are evaluating such a child, you want to know when I am not dealing with CDGP. So what will be the pointers that will point, okay, this girl doesn't look like CDGP.
So your growth was appropriate for it. So her height and weight were not
yes.
compromised.
So her height was normal for age. Second scenario that you were saying is that the age is a bit more. So 16 years in girls is pretty advanced. So it will be a bit later presentation. What about what else?
In favor of CDGP.
Again CDGP.
Again CDGP is again headache.
So headache is a phenomenon which we will ask about. The breast development, generally they don't have any breast development at all. So it may be that she is CDGP and now she is entering puberty. That is why she has breast stage 2 development. But then that is a possibility. So what are favoring CDGP in this scenario?
B2B1 is definitely.
So there is no pubic hair development, which is also effective. So that will be the thing that you have to worry about. So this looks, I would be very wary about labeling this girl as CDGP in this scenario because she is reasonably tall. And then you will ask about the specific other complaints. Any family history of delay was not there in this case. So again, these are the red herrings that you're dealing with, something beyond just CDGP. So now when you go beyond CDGP, of course, you are mainly concerned about a lot of hypergonadotropic hypogonadism. So what are the features of hypergonadotropic hypogonadism that you will get on examination or history?
The hypergonadotropic hypogonadism will be terminal will be there. So short stature, anthropometry will be.
So short stature, typical, all the facial features, skeletal features. So that you will be there. So that was obviously not there in this case. This girl was a normal built, normal statured child. So that becomes unlikely. Of course, you can have some other forms of gonadal dysgenesis which may not have that much abnormalities which are there. Do you think this could be a systemic illness scenario, Vibha?
So in the systemic illness, first of all, as she has said, the weight was appropriate for her.
So you will expect the height and weight to be affected. The child will be more sick in that scenario. So a non-sick child who is not short always think of something which may be sinister in that perspective. Now, you've got breast stage 2. Will you call it a stalled puberty or will you call it a delayed puberty to begin with? What did the parents tell you?
They said that no development has.
So no development. So maybe it is both ways. There was some initial development and then it stopped. So it's difficult to say, but if you get a clear-cut feature of stalled puberty, then you are really worried about certain causes. So what are the conditions which are excluded by a stalled puberty?
If it was CDGP, it would not have a.
So CDGP will never have a stalled puberty. What else do you think, Manoj, if you have a stalled puberty rather than a complete absence of puberty? So what I'm asking to you is that what are the causes in which there is no development at all?
So congenital hypogonadotropic hypogonadism is out.
Congenital HH also. Okay, so if there is a, unless you say it's a mildish form in which you can have some development, so there is a spectrum. But the severe forms of MPHDs are typically lost, but they are anyway less likely because of the height and weight. Then you said congenital HH, yes, so plus minus anything else.
Severe form of Turner syndrome.
So Turner syndrome, I would not say anything on that. B2, I wouldn't be worried about. Turner syndrome, pretty much we can have that.
Systemic illness is the.
Not really, because how much it is affected. So I would say the other thing which will be out will be something like aromatase deficiency, estrogen receptor defect, something which are very, very severe, like in which you have zero function. So that will be out in that regard. So definitely you have got some breast development, means that whatever the illness is not completely knocking off the system. There is some scope of growth there. The other big thing is that if it is stalled puberty, the first thing I will think about is the acquired lesion that you have to be really bothered about. And as I always say, that although most children with delayed puberty may not have a pathology, it may be a marker of a sinister pathology which happened in this case. Now let's go on to the workup.
So initial screening for systemic illness was in the normal range. ASL was in the normal range and prolactin level was normal. FSH was not high and LH was definitely in the puberty, had come into the pubertal range.
Do we have an estrogen level as well? So what we are seeing here is that there is a decreased amount of LH and FSH, but whether it is really low, it's not in the zero range. So if you talk about Calamin and many of those GnRH receptor defects or the defects of FGF receptor or charge, all those scenarios, the levels are much, much lower. So this maybe somebody might say, okay, this girl has now just entered puberty, LH is slightly high, so let's wait and watch. This could be a problem which may happen in this scenario. Okay, why was a karyotype done? So I think that is another big message, that nobody should do a karyotype unless you have got a documented hypergonadotropic hypogonadism. Unless you have done that, why unnecessarily do karyotype in the beginning in this phase? And this is very common scenario. So this is clearly a hypo scenario.
Somehow for delayed puberty, hypoplastic uterus with non-vagina.
So at least they showed a hypoplastic uterus. Often you will get a report of no uterus. So this is of no concern. So as we say, if there is no breast, no uterus, don't get an ultrasound done also. So that is of no consequence per se. And ovary and all, unless you are doing a transvaginal, it's very, very difficult. So I don't give much importance to a pelvic imaging at this stage. So now if we look at this picture, Manoj, what do you think? Do you think this could be CDGP which is improving? Theoretically, yes.
Yes.
Theoretically,
LH-FSH is not that much low. So
yeah, so now it's picking up. B2 has also happened. So this can be a tricky scenario in which you can say, okay, let's wait and watch. This could be a general sort of a dictum. However, the finding of headache. So did you get the headache primary on, were they having this complaint of headache, or was it a retrospective finding?
It was definitely a retrospective finding. It was something that we found on probing whether she had. So she said yes or no, she had.
So that's a difficult scenario. But I think this brings us to a very, very important thing, that if somebody is 16 years, so that's what we have to think in a holistic picture. Otherwise, if you look at it, any approach, it will say, okay, this is like a CDGP / a hypo. But neurological features, so they have to be very cautious about etiology of neurological features, which will be there. So now the big question is, would you do MRI in this girl?
So definitely, she has a she is presenting with a headache, and if she has other neurological, we should go for them.
Yes, so it's a difficult scenario. In a busy practice, you may say, okay, this is CDGP, let's wait. But the message is that if somebody is 16 years and still no development is not there, LH is just marginally elevated, think about a evaluation further. You carry forward.
So it's the same thing. If you go by the application, by definition, this girl definitely fits into the criteria where you would want to evaluate her for delayed puberty. The initial screening was normal, FSH was not high, so here we're not thinking of Turner syndrome. Prolactin was in the normal range and she had headache. So if you go by this, the app gives us an interpretation that this may be a permanent HH. Go for an MRI.
But if we do not go into that history, it will probably say that this will be a scenario in which it will go more towards LH level. And if your LH is like 0.4 or something, it may say CDGP. So that brings a very, very important pointer that you have to think of neurological features. That is the major message, I think, in the beginning of this case. Yeah. So carry forward.
The lesion was hyperintense for T2 imaging with focal areas of T2 hyperintensity instead of calcification. It was anteriorly abutting the optic chiasma and posteriorly abutting the interpedunculaar system. The pituitary gland was separately visualized with the above described lesion. So the treating pediatrician went ahead with an ophthalmic.
So now, if you look at this sort of a picture, I know this is very, very characteristic, but often there is confusion, as we always say, supracellular lesion, which is coming from above and coming down, and a cellular lesion, which is going up. Now, what are the key pointers that this suggests that this is a purely non-cellular lesion, clinically, investigation-wise, and this imaging?
So, cellular lesion, they will usually also have a supracellular lesion may have hyperlactin levels. When it descends down, it may cause anterior pituitary function defects, and in cellular, they may be present upfront. So the endocrine deficiencies may be present upfront.
So the chances of having endocrine deficiencies will be lower in somebody who has a supracellular mass to begin with. Deficiencies will happen when you have surgical intervention, which is done. Similarly, the other thing is that that your prolactin, as you said, if prolactin was high, it will more suggest towards a stalk compression. The LH-FSH levels, what do you think? So both scenario, if it is causing obstruction, they will be low. But one important pointer on imaging is suggesting that this is purely a supracellular lesion.
So a figure of 8 appearance.
Anything else which is there in this MRI that you have mentioned? Pituitary is separate. So if normally we say, even if you see a rim of pituitary around the lesion, that itself is a separate thing. But here it is classically, this is not there. So now if we talk about a girl who is 16 years old, who definitely has had this lesion, not now, for quite some time. This has to be there because though puberty has happened maybe few years, a large lesion with this sort of a pattern with calcification, I think there is no differential in terms of that. So this will be a craniopharyngioma, which is classically there in that. Yeah. Carry forward.
She was shown to an ophthalmologist this special field of here. So like sir has said that a 16-year-old girl presenting with delayed puberty who has a pre-puberty development on examination with a normal lesion height, normal vision examination. With this classical MRI image, there is no other differential that comes to my mind except craniopharyngioma. So we know that craniopharyngioma is an embryonic remission out with an incidence of 0.5 to 2.5 cases per million population. Of these, 30 to 50% patients are from the pediatric age group with an equal male and female incidence. The location of origin is supracellular 95% of the cases, but when an imaging is done at the time of diagnosis, the most common location that the lesion is seen in is the supracellular cellular combined region, with isolated supracellular and isolated cellular lesions being less common. The tumor is locally invasive and distant metastasis is also here, but mainly caused by scattering of cells.
So is it a benign lesion or a malignant lesion? So it's a benign lesion, but its location is such that it behaves malignantly. For that person, it is going to be bad.
There are two doctors. Yes. So the common location is below the lower dotted line. If it is between the two dotted lines, then that is anterior extension and it will involve the anterior part of hypothalamus. And if it causes a lesion, progresses to the mammillary body or beyond, that is a posterior invasion of the tumor. Histopathologically, there are two subtypes, adamantinomatous and papillary. Adamantinomatous is the most common with bilobal age distribution, being common in 5 to 15 year age group and again later at 45 to 60 years of age.
So this one is which variant you think?
Is adamantinomatous.
Because calcifications are also present, that is the classical features.
Calcification.
What do you mean by adamantinomatous? How does the name come from? Teeth, bone. So that's why the appearance, so they found calcification. So that is from the teeth. It is coming. Yeah.
The papillary is commonly seen in animals. Molecular wise, adamantinomatous is classically shown to have CTNN-D1 mutations and papillary has the BRAF600 mutations. The initial clinical features are often non-specific, leading to a lag in diagnosis, with median time to diagnosis being 5 to 12 months from onset of symptoms. Primary symptoms are due to stages of raised anxiety like headache and nausea and may be ignored for a very long period of time. If you look at the frequency, yes. So the bars in white describe prevalence of symptoms during because of craniopharyngioma, and the bars in black describe the individual symptom being the initial manifestation in children that brought them to the hospital. Now, we see headache was the most common feature in these children, and also being the most common presentation at that initial presentation to hospital, followed by visual impairment, growth retardation, vigilance, diabetes insipidus, and weight gain. The numbers over the black bars denote lag in diagnosis. So, from the onset of headache to the point craniopharyngioma was diagnosed, there is a lag period of 24 months. This period was minimum when vigilance was affected, and this lag period was maximum when growth retardation was seen in children.
So, because we would be biased towards getting patients who predominantly present with endocrine manifestations, but still, I would say most of them are post-operative that is presenting with this thing. But delayed puberty, yes, we have had a few patients with delayed puberty. DI also 1 or 2 patients which are there, but most of them are post-operative which will be there. But yes, they can present just like this case with a specific endocrine manifestation like that child Sumit who comes. He also was diagnosed as delayed puberty and then was found to have craniopharyngioma. So I would say delayed puberty is one thing which is very, very important, and short stature, of course. Yeah. Carry on. Yeah.
So again, as Susan mentioned, endocrine manifestations in general have present 40 to 87% of the patients, and this percentage increases in the post-operative patients. The most common endocrine deficiency seen is growth hormone deficiency, followed by gonadotropin deficiency. There's an equal presence of TSH and cortisol deficiency, 25%. What I want to highlight again is that DI may be present as the initial manifestation in 17 to 27% of children with craniopharyngioma. In the perioperative period, this percentage may go as high as 80 to 100%, and in the post-op period, probably DI may be present in 40 to 93% of the patients.
And the other thing, rarely you can have precocious puberty also, rarely you can have SIADH also. So you can have a manifestation which is there.
Diagnosis is mainly by imaging, by CT head or MRI, hypothalamus pituitary region. And as we know that adamantinomatous is the one with calcification. To pick up these calcifications, CT is the preferred modality. But if for any reason you wish to avoid a radio exposure, the best alternative is T2 star imaging. The imaging features of adamantinomatous craniopharyngioma follow the 90% rule. That is, 90% are predominantly cystic, 90% have prominent calcifications, and 90% take up contrast media in cyst walls.
If you have any girl or any child with delayed puberty, although we say, okay, most of them are physiological, we don't need to worry about the cause. But then if you have a cause, if you are labeling anybody as hypogonadotropic hypogonadism, you have to do an MRI. I think that's a big message which is there. Now, once we diagnose, the challenge starts from there as to how do we manage. And the management, of course, comes in the neurosurgical domain, but there is a lot of endocrine issues also, which are there both pre-operative, peri-operative, and post-operative. So we will now have a discussion in that perspective. And if we now look at from there, Dr. Vibha will basically be talking about how do we do a peri-operative care in this scenario.
So moving on to the management and index case. For her craniopharyngioma, a gross total resection was done by right pterional approach, and the histopath was suggestive of histopath showed an adamantinomatous craniopharyngioma, which was in sync with our clinical diagnosis. Moving on to the anterior pituitary functions. So we know that the pre-op values had shown a subclinical hypothyroidism with normal cortisol levels. However, function done in the post-op period, about 3 days post-op, showed low FT4, low TSH, and low cortisol levels. Thus, diagnosis of MPHD was made here. So for MPHD, she was started on hydrocortisone followed by thyroxine. Looking at the posterior pituitary functions, so just immediate pre-op, her sodium potassium were in the normal range. In the 2 to 3 days post-op period, the child was found to have polyuria with a dilute urine on urine routine exam, low urine specific gravity. Thus, a temporal relation of surgery with polyuria and in presence of sodium hypernatremia, a possibility of DI was considered here in this case, and vasopressin was started, although no urine osmolarity was done in this child. She was started on vasopressin, on which her sodium levels began improving. She went on to go to the hyponatremic side. Thus, vasopressin was tapered and stopped here. Cortisol and thyroid profiles were done and they were found to be in the low range, for which hydrocortisone was started. Upon starting hydrocortisone, within 10 days of starting hydrocortisone, the child again developed polyuria and there was unmasking of DI here in this case.
So I think this is again a message that we always say, if you start on hydrocortisone, you expect DI to happen. So this is what again was happening.
So this R index child had shown a triphasic response of DI, SI, DH, and DI again. So for DI, desmopressin was started here. So as we've seen, we've managed the craniopharyngioma part, we've managed the anterior and posterior pituitary deficiencies that this child had. What remains next is that we monitor her for hypothalamic complications, and although she did not have anything at the current visit, but this is definitely something that we should be monitoring her growth. Pubertal induction is something that will come up next in this curve.
I think the big thing here was that this probably came up at the right time because she did not grow to a big lesion and the site was also good. So I think this was an interesting case in which we focused a lot of discussion about pre and post operative evaluation. Dr. Priska is asking, please explain why if morning cortisol is normal and AC stimulation test must be done. So if your morning cortisol is very high, in the sense that if it's above a supranormal range, then you can avoid it. But before you go for surgery, maybe a AC stimulation test will definitely be of help in that scenario. Dr. Bharani is asking, craniopharyngioma is a growth without GH state. How decide the need for GH supplements? Definitely, this is a very, very important question that Dr. Bharani has put in, that as discussed, because of the insulin resistance due to obesity, they will grow in the initial 1 or 2 years. Now, what we usually see is that after that, the growth velocity really falters down. And in that scenario, often you can do a IGF-1 level, which will be low. Now, in this scenario, you already have a multiple pituitary hormone deficiency. If the IGF-1 is low, you can diagnose growth hormone deficiency then and there. You don't need to do a growth hormone stimulation test. So it will largely be clinical. So anyway, 1 year, we don't need to treat. We will wait and watch, and usually by 2 to 3 years, we had that scenario. The boy who was coming the other time also, in which they were initially he was tall, and then suddenly his growth became 0. And then we had to give growth hormone, pubertal induction. You can all go and have a look at our website where we have got resources like this and the courses and the mobile application. You can all go and have a look at our website, our courses which are available, and the mobile application. So